Put up that poll. Thank you. We are recording. Got it. If you can go ahead and put up the poll. Great. Thank you. Just take, if you could answer that question quickly. So how confident or comfortable would you feel in a meeting with state officials and other parties to discuss Medicaid payment policies for CHW services? So please just choose one of those and submit. So we'll give that 10 or 15 seconds, Donna, and then we can go ahead and close it out. Okay. Well, there are a couple of you are very confident. That's good to see, but we're going to invite everybody to share with each other what you do know. But we're hoping that you will feel more confident by the end of these 2 hours. So great. Thank you. Thank you very much, Donna. Okay, so I'm going to jump in here with going back to some very basics about what is Medicaid and why are we talking about it now. And by the time we get done, we're going to be talking about the specifics of how Medicaid payment for the activities of CHWs can be both very important, but it can have an effect on how you do what you do. So this is these are important considerations. So first of all, just the very basics. Medicaid is called medical assistance in most states, or something like it, and it is an entitlement program, meaning that if you meet the eligibility requirements, all you have to do is apply to receive it. But it also means that the state and federal governments regard this as mainly a way of paying for medical care for low-income individuals. And so that automatically starts us off a little bit on the wrong foot, because obviously community health workers do not provide clinical care. The other really important principle, which I'm sure most of you are aware of, is that it is a federal state partnership. Unlike Medicare, which is a purely federal program, each state has its own plan for how Medicaid is going to be offered in that state, and they do differ quite a bit from one state to another. And again, many of you may know some of these things, but we're certainly going to go over them quickly. The Medicaid was sort of officially born, if you will, under amendments to the Social Security Act. It's known as Title 19 of the Social Security Act. And this was part of President Johnson's Great Society initiative. It began at that point. Arizona finally came on board. They don't even call their program Medicaid in Arizona, but they joined in 1983. And the eligibility for the program, it has not always been the way it looks today. I'll just review that quickly in a second. But eligibility for Medicaid has gradually expanded from the very beginning. When it got started, the federal government started paying for nursing home care in 1950. This is still under the Social Security Act. The amendments that I just mentioned in the Johnson administration added some categorical benefits, but they were medical benefits. And it really started with the recipients of what was simply called welfare at that time, cash assistance, which is now known as TANF. And then a very important step was the addition of well child care, the EPSTT program in 1967. Then pregnant women and children added in 1989. A lot of this is more recent than many of you may be thinking. Younger kids were added above the age of 6 in 1990. And then the CHIP program came along, which enabled states to provide coverage for kids above the Medicaid income levels in 1997. And then finally, Medicaid expansion with the Affordable Care Act, which of course South Carolina has not availed itself of. I know it has been a subject of great debate as to whether the state is better off with it or without it. Don't want to get into that with you, but it does change the picture somewhat. An important consideration, again, which many of you are already aware of, is that the income limits for eligibility vary by the different eligibility categories. And I won't get into this, but the choices, states have made different choices about what income limits they want to utilize above and beyond the minimum that the federal government specifies. But this has been the subject of a lot of waivers and state plan amendments over the years. So I'm going to start right out at the beginning because a lot of you have a good deal of experience with Medicaid, maybe not so much with what we call the back end of Medicaid, which is where Medicaid decides in terms of policy what kinds of services are going to be covered and how they're going to pay for them. And many of you, I'm sure, are very familiar with the front end, if you will, about how Medicaid affects recipients, people in the community, and advising them about how to access benefits and that sort of thing. But a lot of you have very little exposure to the back end, as I just called it. So we're going to go to small groups, Donna, here in just a minute. And we're going to take, let's say, no more than 10 minutes on the following questions. And be ready to report out, again, in the interest of time, appoint one member of your small group to type the answers or summarize the answers from your small group to these two questions. What is one thing you know about Medicaid that you think others in this workshop might not know in terms of where you have particular experience that you can contribute to the group? What's one thing you know about Medicaid that others might not know? And we've only covered a little bit in the beginning, but is there anything you've heard so far that has surprised you? Because we hope this is going to be expanding your knowledge of Medicaid. So let's go ahead and start the groups. Donna, please give them 10 minutes. These will be probably groups of no more than 5 or 6 with this size group. So let's please go ahead and do that.
Mr. Rush, what was the second question, please?
Second question is, what is one thing you've already learned so far about Medicaid that has surprised you? Maybe nothing has, but most of us have found there's something here that you didn't know about. Okay, Donna, let's go ahead and move them into small groups.
Do you have a request that says accept room, Ms. Noman?
I'm sorry.
I said, do you see where it is requesting you to accept a room? There
I
you
do
go.
not.
Oh, you
actually.
don't? Okay, let me see what I can do then, because I see. Okay.
There.
Okay.
Yes. All right, everyone's in.
Thank you. So let's Give them no more than 10 minutes. I had
Right, I
given
set it up for
people-
10 minutes with a 30-second.
Okay. Looks like we have somebody who may have just joined.
Yeah, Marek has just joined. I'm gonna assign you, Marek, to. There you go.
Thank you.
You're
Uh-oh.
welcome. Hey,
Hey, send that to me again.
all
It
right.
disappeared.
Let's see.
It was one, I think it was.
It
All right.
was
Well,
one.
that's okay. Cool. Thank you.
You're welcome.
Bye-bye.
Okay.
All right. Off to the races.
Off to the races. I think we have about 30 now. A number
Uh-huh.
of people were late because it required them to put in a password. So
Oh, okay.
that always is a challenge. They don't realize they have
Yeah,
to go
that's
back
fine.
and look for it.
Yeah. Well, this is a pretty manageable size group. I'm still going to invite them to report out from their group in the chat, just so we can move forward
Okay.
rapidly. And I'm going to try and save the chat record myself. I imagine you will probably do that too. So
Right. So if you don't have it, I can always send it to you. And usually what I do is I take our all of our webinars and put them up on our YouTube site
yeah.
in a restricted format. So I'll send you the link afterwards.
Okay, great. And then I need to send you the final version of the slides as well. I'm
Yes.
certainly happy for people to have a copy of
Yes, they will be asking for them.
that. No doubt, no doubt.
But yeah, this is
Okay.
pretty cool. And I didn't get my water, so I'm going to get my water right now.
Mm-hmm.
Hello, Chief Mitchum.
Hello, how are you?
I am good. It's so good to see you. They're in the middle of breakouts and they have about 3 minutes. Would you like to join a room?
What do you know what they're talking about? I
Yes,
mean, I don't mind.
they're talking
Question should
about,
be on the screen. Yeah.
yeah, I think they'll have the question right in the screen.
Okay.
All right, hold on. I'm gonna put you in a room. Wait a second. Wait a second. You should see it on your screen now.
Oh dear.
I think she kind of froze, so I'm not sure
It
whether
shows it on my screen too. Yeah.
I'm not sure whether she got in there. Well, it looks like she's in there.
Yeah, she's in now. Yeah. Okay.
So they have about 3 more minutes.
Okay. I did a fair amount of tinkering with the PowerPoint. This is only really the second time that I've delivered it, but
Oh, really?
yeah, we've learned some things.
So the one I saw with the national was your first?
No, this is different from what I've presented nationally. This is a much more detailed look at Medicaid, and it was developed and delivered the first time to the Rhode Island CHW Association.
Okay. Our friends in Rhode Island. Awesome.
Yeah, they had some more detailed analytical data on the program itself in Rhode Island. I wasn't able to find the same kind of detail for South Carolina, so I do have some comparisons.
Yeah, Julie and I both had people looking, but we weren't, I guess, able to find exactly what you were looking for.
Well, and that's fine. I mean, these are not central to the CHW initiative, but I think they're valuable for people to get a perspective on it, that there's a lot of variation within the Medicaid program in terms of who they're covering and what the costs are and that sort of thing.
Right, right.
And so it's important because those are considerations that are in the mind of state officials, I think, a lot. And so I will make that point, but it's it's a more complicated program, I think, than a lot of people realize. And so it's good. We may have occasion to do a deeper dive on some things if the participants, if the association wants to do something more looking at particular aspects of this. I'm happy to do that.
Yeah, we've begun that discussion a number of years ago. So I think there has been some frustration on the pace of movement and the roadblocks, perhaps.
Yeah, yeah. Well, as what I'm seeing, it is not easy in any of the states that have tried to do this.
Right. They are on their way back.
Okay, great. Filing back into the room. Here we go. Excellent.
Okay, I think we have everybody.
That's terrific. Thank you, Donna. Okay, so we're going to move forward, but looking at these questions again, if you can have one person from each of your groups type a brief response in terms of what came up in your group in response to these questions for the record, and please do as you can through the rest of the program, take a look at the chat and see what the other groups are saying. It's important that you hear from each other as well as just having me yakking at you. So Good. If everybody's back, I'm going to move forward. So picking up from where I left off, these are the sort of general guidelines. The federal guidelines are the green column in the middle. You can see that the income limitation, this is the family income, obviously.
Oh, I'm
Um,
sorry. Carl, are you sharing your
Oops.
screen right now?
I was.
No.
Oh, okay. Well, no wonder. There we go. I'm gonna have to restart it after, I assume, after the other breakout too. Thank you, Donna.
Well,
Okay, people see it now?
yes.
Thank you. Okay, so the eligibility categories are in the left column in blue. And you can see that federal policy is to pay for care for children and pregnant women at higher income levels than other eligibility categories. But you can also see on the column at the right, each state has the option to finance coverage for families at higher income levels than the federal minimum. And you can see there are a few states that are paying at much higher levels for some of these categories. It tends to be, and I'll come back to some reasons for this, but the disabled and elderly, the income levels, the states tend to not go much higher than what the feds require. And that is because those populations cost a lot to care for. Okay, so that shouldn't be any big surprise. But we are finding that it's beneficial to most states to pay for coverage to kids at higher levels of income, in part because for healthy kids, particularly between the ages of 1 and 6, let's say, for example, the actual cost of care for that population is not very high. And so if they are covered under managed care, for example, the premiums or capitation payments that those health plans get for kids from 1 to 6 are pretty low compared to healthcare premiums for other populations. So this is a kind of a reference. You all will be getting a copy of these slides to use for your reference later on. But this is just to show you, I'm not getting into the details of what the levels are in South Carolina. You probably are all pretty familiar with those. So moving right along. So, and again, please continue to, if you joined the call a little later, please do fill in the chat your name and organization for the record. And again, please, the reporters for each of the small groups, please put some notes from what your group came up with in the chat as well. So Medicaid is not uniform, even within one state. Most states pay for services in a variety of different ways. And these include fee-for-service and what may be described as alternate payment models. And we will only touch on these briefly today. If you all want to spend some more time talking about what those look like, that's fine. And managed care is sort of in between. South Carolina has the regular Medicaid managed care plans, then also a model called the Medical Home Network, which is a what is considered primary care case management, where the management of the care, it resides in the medical home or the primary care practice. But these are the basic strategies that states are using. Alternative payment models include value. I'll get into this a little bit more in a second. Value-based payment, alternative care structures, which are called generically, they're called accountable care organizations. For example, in some states, they're called different things. In Rhode Island, they're called accountable entities. In Oregon, they're called coordinated care organizations. But this is actually changing the organization of the way care is delivered. It's not just a way of paying for them. And then, of course, the federally qualified health centers have, in most states, their own payment system, which is called prospective payment system. They're paid per visit rather than per individual service. So a little more on each of these. Fee for service is what we talk about when we describe, when we talk about reimbursement. We're generally referring to fee for service payment. So in this case, the provider bills the state, or in some cases, the managed care plan, for individual units of service, like an office visit, and they bill after the service has been delivered. So that's why they use the term reimbursement. And the even in states like South Carolina, which are largely covered by managed care, those states also pay for some services using fee-for-service structure, mainly in the long-term care arena. So even the managed care states are not purely that. The fee-for-service providers, though, one of the criticisms of fee-for-service is that the providers can maximize their revenue by providing as many services as they can. And so that's an incentive to pay for volume or quantity rather than quality. And that's why there has been so much discussion about alternative payments, so that they emphasize something other than billing as much as you can. This is a legitimate concern in a lot of states. These alternative payment models are meant to create incentives to provide better quality care, to promote health equity and reduce disparities, to improve access, and so forth, so that the payment system is specifically structured to incentivize that. It's sometimes called value-based payment. And there are different models within these alternative payment models. In some cases, it's just fee-for-service plus incentives or bonuses for meeting certain goals, particularly for like preventive care. If you're a provider, the better you do in providing preventive care to your patients, the more revenue you can generate. Then there are some systems, it's been done a lot in Medicare so far, but increasingly in Medicaid, where an episode of care, one of the early examples that states experimented with was a bundle payment for, let's say, a knee replacement, because the costs of that are fairly predictable. They can just say, okay, we're going to pay you this much for a knee replacement, and that's all you get. Okay, so they don't have billing for individual office visits or things like that. Now they're going in the direction of, with larger organizations in particular, to share financial risk, which means you'll get a certain amount of money for the services you provide. And if you economize, if you control costs well, you can do better financially. That would be called sort of the upside risk, they call it. If you do well at providing care efficiently, effectively, you can make more in terms of profit or surplus. If you do less well, you're going to be penalized because you can be losing money. And then the ultimate in the form of alternative payment structures is called capitation, which is how the Medicaid health plans are paid. You would get so much per member per month. And in other words, you're paid in advance based on how many members or patients you have before the services are delivered. And the payments are adjusted based on the type of eligibility, the type of patient, the degree of risk, medical risk that patient has, and so forth. But you're expected to cover all of the costs related to the care of that individual out of that capitation payment. So this is the ultimate in risk. Now we talk a lot about this stuff. Most states haven't gotten very far in implementing alternative payment, but they are for example, in Massachusetts, they're talking about maybe as soon as next year, paying primary care providers on a capitated basis. So everything that's involved in primary care for individuals would be covered under one advance payment that they would get. And they are explicitly thinking about how should we include the cost of CHWs in that capitated payment. So this is potentially a big breakthrough. But I say that to say that you're going to hear talk about alternative payment models, but most states, and probably I don't know that much yet about South Carolina, they probably haven't gone that far yet. Managed care, most of you are quite familiar with that. As I said, they get monthly premiums depending on what kind of patient, let's say a pregnant woman or a child from 1 to 6 would have different premiums or capitation rates. And the managed care organization, the health plan, must pay for most services to that member out of the revenue that they get. There may be some exceptions. We don't really have time to get into some details of those exceptions. But health plans, for the most part, pay the providers then in turn using fee for service. So even though managed care is implemented, the provider probably is still looking at the same kind of billing system. Now, all that said, what we've been seeing around the country is that a lot of health plans or MCOs under Medicaid are already paying for community health workers or employing them directly, which they can do without any further permission or forgiveness, I guess, if they treat it as an administrative expense. And there are limits to how much they can have in the way of administrative expense, but they can do this now, and a lot of them are. And I'm sure you all have examples in South Carolina of health plans who are already paying for CHWs and treating it as an administrative cost. South Carolina is not unusual in that about 80% of Medicaid recipients in the state get their services either through one of the 4 regular health plans or the medical home network. Okay. Now we're going to break again and talk a little bit more about some of the basic stuff we've just been talking about. So this will be a little bit shorter, but in your small group, please be ready to report again in the chat on this question. What is the most significant thing you've learned so far about how Medicaid pays for services? Okay. Again, no right or wrong answers, and you don't need to try to pretend to be more knowledgeable than you in fact are. You're here to learn from each other. So this is your question. Let's take 5 minutes in a small group for that. And Donna, if you could please do the honors.
I know some of you have just joined after the breakout. If you were in a breakout room previously, can you let me know and I can put you back into that same breakout room?
Donna, this is Sarah. I just joined, so I'm gonna need a new room.
Okay,
Yeah, I'll need a new room too. This is Trisha.
okay, hold on. I'll put you guys in a room that's not so crowded. Okay. Hi, Trisha.
Hey, how are you?
I'm good, thank you. I'm going to put you. Okay. The Centrell.
Yes, I'm driving along.
Okay, I understand. And Lily, I think you were in a room, but here you go. And I know if you're driving, you may not be able to accept. Don't want you to have an accident.
Certainly not.
Mm-mm. Okay, everybody has opportunity to be in a room.
Great. Thank you.
We have about 2.5 more minutes left.
All right.
I think we're all back. Let's see some stuff in the chat. So I think we can look for at least one person from each group, the lead, to go ahead and put in the chat some significant things you've uncovered regarding the question, what is the most significant thing you've learned so far about today about how?
Okay, I just realized that I was chatting away on mute.
Oh, wow.
So, yes, thank you all for those. I was starting to say that SCCHWA will be able to use these comments to plan some further discussions about how to approach conversations with the state. And so this is really, really significant. I'm going to move on. We have a lot of stuff in to get to, and before we wrap up, so just some kind of scoping thoughts. We hear a lot about Medicaid being kind of an increasing cost to both federal and state governments. It is big. In 2019, the total spending between federal and state was over $600 billion. And for many states, it's the biggest single item in their budget. And one of the reasons that's important is the state doesn't have total control over that. Part of it is that because it's an entitlement, if people meet the qualifications and they apply properly, they must be covered. That's the nature of an entitlement. So there have been, because states are nervous about this increasing cost, there have been some proposals to make Medicaid into a block grant to the states, so they don't have to spend any more than they get in that block grant, that sort of thing. This is a long conversation, certainly, but it is a very important one. So by comparison, South Carolina in the same year spent about $6 billion, and 60% of that money was federal money. And that was serving a little over 1 million total recipients. The total number of recipients has been increasing. It probably has increased during the pandemic. So it is a continuing source of concern. So we mentioned there are different categories of recipients. The reports that I've been able to find show that this is very similar to the experience of other states, that adults and children are about 3/4 of the recipients, elderly and disabled are 23%, but look at the difference in expenditures. Elderly and disabled are less than 1/4 of the recipients, the enrollees, but they incur more than half of the cost of the program. Okay, so there are different kinds of concerns on the part of the state and policymakers, but different concerns between the various categories of recipients. As I mentioned earlier, children, especially young children, by and large, don't cost the system all that much. But clearly older children and adults do. So in comparison, I mentioned that I have done this, and this was developed for Rhode Island. They have a little more detail in theirs, and they are also an expansion state. You will see the expansion recipients at the bottom. But one of the ways of interpreting this, again, that adults and children show a similar kind of ratio. If we combine the expansion, which again is many of the expansion recipients are adults in Rhode Island, you got 78% of the recipients representing a total of 40% of the expenditures if you combine expansion and children and families. And I guess you should include in those children with special health care needs. That's the gray bar towards the bottom. And again, elders and adults with disabilities are about 17% in Rhode Island of the 17% of the recipients, but represent more than 50% of their expenditures. So the pattern is very similar from state to state. And there are a lot of the focus of community health worker programs dealing with Medicaid recipients may very well deal with prenatal, perinatal, and children's health and that sort of thing. But that is only a quarter or less of the spending by the Medicaid program. So this says a lot about what you need to be discussing with the state about where community health workers can have an impact. One of the reasons I bring this up is that people who talk about the impact of CHWs and particularly financial return or cost savings, they will point to the experience of many programs around the country where CHWs are working with high cost recipients or high utilizers or frequent flyers in the emergency room, that sort of thing, which is an area where CHWs can help the state save a lot of money, but it's a small percentage of Medicaid recipients. Okay, so this is important for you all to keep in mind as you think about discussions with the state. In the Rhode Island example, again, I couldn't find similar detail for South Carolina, but in the Rhode Island example that I cited earlier, they define a high cost recipient as more than $15,000 a year in cost to Medicaid. It's a small percentage of their recipients, but they consume 73% of the total cost of Medicaid for Rhode Island. So understandably, they are concerned about this. 9% of their Medicaid recipients are considered high cost, but they cost almost 3/4 of the spending in the Medicaid program. I bring this up because, yes, this is a strategy that you can use in discussion with the state. Here are some areas where CHWs can be of benefit to the Medicaid program. Yes, definitely. But you have to balance that. I'm sure you will want to balance that with the fact that it is only benefiting 9% of the Medicaid recipients in South Carolina. And you will have some concerns, I'm sure, about equity and the sharing of benefits of the impact that CHWs can have. So this becomes a strategic question. Okay, so the CHWs can help in different ways with different populations. So if that's the case, why aren't we doing more about this in around the country? Why are most states not paying for CHW services out of Medicaid? First of all, as I mentioned at the very top of the presentation, the program is providing medical assistance. We need to find a way for what CHWs do to be considered part of medical assistance, even though you are not providing clinical care. I'll come back to the details of this in a second, but the Medicaid program in regulations define the mandatory services that state Medicaid programs must provide. And CHWs are not in that list. So they must be treated as an optional service that the state is choosing to provide. CHWs are also not defined in the Medicaid regs or in the Social Security Act as providers in Medicaid or Medicare. There is some hope in the fact that states have made progress in getting Medicaid payment authorized for doulas and peer support specialists who operate in a very similar way to CHWs and have a very similar skill set. So there are some things that we can learn and benefit from in terms of the progress that doulas and peer supporters have made with Medicaid. I mentioned the table of mandatory services. This is what, there are some additional services that were authorized for those folks who are newly eligible for Medicaid. I won't go into detail on this. You can look at the slides later on to refer to it. But among the optional benefits, there are still limited opportunities for the state to define what CHWs do as a Medicaid service or a Medicaid benefit. The closest we get, I think, although this is not without controversy, is case management. There are definitely roles that CHWs can provide in case management, but thinking about how CHWs tie into the other things that states may choose to cover under Medicaid is an important direction for your thinking. Now, all of that said, an increasing number of states are interested in CHWs. And this is a very exciting time because of that. Why is this changing? Well, of course, we all know that states are under pressure to improve care and control costs, and CHWs can help with that. There is a very welcome emphasis on health equity and social determinants in all healthcare, but especially under Medicaid. And again, the good news, without going into a lot of detail, I think you're all aware that CHWs can have an impact in this area as well. But the larger point, I think, which we haven't really taken advantage of, is that healthcare is changing. And what do I mean by that? Basically, healthcare is shifting from what we would call a transactional model to a relationship-based model. What do I mean by transaction? Well, it's like buying something. You experience a health issue, a problem. You seek out a provider who can help you address that problem. They provide a service, and either you pay for it or somebody else pays for it. That's a transaction. And there are a lot of reasons why that may not be the most effective or efficient way to provide or pay for healthcare. And so it's kind of a one-to-one thing. I think of it sometimes as kind of a vending machine. You experience a need, you walk up to the machine, you put in a credit card probably, and you get a service and you walk away. There's no relationship there. I thought it was kind of ironic, this photo that I got, that the vending machine is dispensing bacon, but I don't want to spend too much time on that. What we're shifting to, though, is relationship-based, which is centered on the patient and family, and it is meant to treat the whole person, to treat the family, to work on the basis of a relationship with them. And we know that this is very challenging for providers who operate in the Medicaid space. The simplest example I can tell you is I've heard this a lot with audiences of Medicaid providers. When we ask, have you ever seen a patient record that said lost to follow-up? And you see a lot of nodding of heads and hands go up and so forth. They've all seen this. It makes it hard to provide good care. And the good news is that relationship-based systems like medical homes or accountable care organizations are based on relationship. If you're running an accountable care organization, you can't lose people. It's not okay. All right. And again, the good news about this is that CHWs are expert in establishing relationships with that very population, in establishing trust, in establishing honest communication. And so the system is saying, hey, you know what? If this relationship-based model is going to work for the Medicaid population, by golly, we need CHWs. So what are the steps that we're looking at here, which is what is your conversation going to look like between CHW leaders and the state and other interested parties and the state about this issue? One of the things you're going to need to find out is what services are most important to Medicaid itself. Okay, what kinds of things will help Medicaid do its job? And that, I think, most states, they will be very candid about where they need help. So let's figure out how you can do that. Once you figure that out, you need to decide on how the services are going to be paid for. That's a longer discussion, and obviously it's going to be helpful for you to become as familiar as you can with the alternatives for payment methods so that you can make suggestions. You can help them find solutions. Once that's done, it's going to be necessary, probably together, for the state to figure out what the costs are going to look like and what the budget requirements are going to be and how they're going to pay for the costs of getting this started. And then lastly, the state needs to approve it. There are budgetary approvals. There are a variety of program approvals internally, and they're going to have to make application to CMS, to the federal government, for either a waiver or a state plan amendment to implement the things that you've agreed on together. Okay, so that's what the basic process looks like. Now, here's where the rubber meets the road. We are finding, I've had the privilege to work with a number of states as they're thinking about a state plan amendment to Medicaid for how to do this. And there are a lot of variables that they're thinking about because what CHWs do is so different from the other things that they pay for. And we can talk about some examples from other states, hopefully, before we're done here. But here are some of the issues that seem to be coming up in these states about how you design a payment program. And one of the most basic ones, which will be no surprise, is what services will be covered. Now, remember that Medicaid is used to paying for medical care, for paying for specific medical interventions, specific services. And I think there's a challenge, as you all will recognize, in the way community health workers operate, that it's hard to capture what you do as a specific identifiable service. It's more of a process even than anything else. Okay. I know a lot of CHWs that I'm acquainted with don't even regard what they do as providing services at all. And so how are you going to package what CHWs do in a way that looks like services that Medicaid recognizes? So what we're hearing in these state plan amendments is things like health education, is preventive services, which I'll come back to in a second, is coaching and care coordination. And that term, the care coordination, can be tricky because it looks like care management or case management. And there are other professions that say, whoa, wait a minute, we do that. So maybe care coordination is not the best term. But there is health promotion, which kind of overlaps some, as you might imagine, with health education, but it can have to do with addressing social determinants. There are a lot of variations on this, and there are some fairly progressive ways of looking at it, so that there are possibly roles for CHWs in being part of care planning, being part of patient assessments, okay, which may involve part of the history that is taken for a patient. There may be some aspects of direct observation of the patient's living situation, which CHWs are in an excellent position to contribute. There may be, when we talk about health promotion, there are issues of addressing barriers to care, but there are also issues of the patient experience in a provider encounter, like a physician office visit. So Rhode Island, for example, is talking about being able to pay for a CHW who accompanies a patient to an office visit with a physician for a variety of reasons. One, to increase their comfort level, to help to overcome some of the differences in power between a low-income patient and a high-status medical provider, to be able to recognize when there is possibly cultural content going on in the interaction between the patient and provider, and to stop for both parties to say, maybe we should recognize something that might be going on here. What do you think about this, right? To make sure that the patient fully understands what the provider is telling them, and encouraging them to be honest about that. We've all heard examples of patients who, in encountering a physician, will say what they want the doctor to hear, or what they think the doctor wants to hear, okay, rather than their truth about things like prescriptions. Okay. They think the doctor wants to hear that everything's going fine with the medications that they've been prescribed, when maybe they couldn't afford them or they had bad side effects, and they don't want to say that. And the CHW can help them in being honest and candid with their provider, things like that. So those are all really crucial in terms of the choice of services that you want Medicaid to cover. There is also a matter of, and I didn't really have a bullet point on this, but Medicaid only pays for services that are considered medically necessary. So it's very important that you help the state to define the conditions for medical necessity. So things like barriers to care and social determinants. I don't want to jinx anything, but Rhode Island has included in its definition of medical necessity for CHW services that the patient herself or himself says, I need the help of a CHW. That would be enough for the state to say, okay, we will pay for these CHW services, which is a huge breakthrough. Okay, so that's all part of defining what services will be covered and when, you might say. One of the big ones we've seen in various states is how much time you can spend with that client, that patient, that community member. And a number of states have them embedded in their state plan amendment. But I'm pleased to report that Rhode Island and California have dropped the idea of limits, because they recognize that the interaction between a CHW and a patient is way too fluid to put rigid limits on it. There's time that needs to be spent developing and maintaining a relationship. And so I think they're finding that placing limits on how much time the CHW can spend with a patient is not a big concern in terms of the cost of the benefit. Okay, that's all really good news. So it also is reducing, as I say, what CHWs do to discrete services. And it's really hard to do that. It doesn't really fit the way CHWs work. The rate of pay, I guarantee you this is going to be controversial. Okay, you start with the fact that Medicaid providers generally believe that Medicaid's payment rates are too low across the board. This is in the context where CHWs are struggling in many states to achieve a living wage. Okay, so this is going to be a big part of the conversation. And part of it has to do with what parts of their time Medicaid will pay for, under what circumstances. But it also speaks to the fact that the organization that employs the CHW has other costs associated with employing the CHW: supervision, infrastructure, IT, all of that stuff, travel expenses that the employer has to deal with in order to properly support the CHW. So this is going to be a big part of discussions with the state. I can guarantee it. But it is part of NACHWA's mission to support the argument for a living wage for CHWs. And you can make, I think, a very clear case that if you're not paying people a living wage, you're going to have a lot of problems with turnover. And so it's better for the employer and for the state if you pay people enough that they will stay in the job rather than move on. And I think it's only justice as well, fundamental justice. So that's going to be a big issue in designing the payment structure. Another big one, which I was a little bit surprised at, is the settings. In order for regular billing of Medicaid, you have to have a number of things. You have to have a diagnosis. The service is being provided in response to a diagnosis. The good news is that even in experienced states like Minnesota, they're starting to use what they call Z codes that represent social determinants. And that can be the reason for the service. It doesn't have to be because the person has diabetes or pre-diabetes. Okay, it can be because their housing is unstable. Their housing situation is unstable. That's good news. So they're doing that now in Minnesota, and that can be part of this consideration. But a big one, the other requirements are you have to describe what the service is. It has to be a billable service, of course. It has to be referred or ordered by a licensed clinician. And you have to define who the billing provider or supervising provider is. And they have to be authorized to bill Medicaid. So all of those things have to be in place in order to do that. But it also has to specify what is the setting. Is this service being provided in the community, in the home, in a clinic, in a hospital? That has to be described and coded. And in some states, there are interest groups who are saying, we don't want CHWs to be paid for services provided in the clinic because they think it competes with what they're doing. There are ways around that. There are strategies around that that we can discuss when we get into more detail about this stuff. But there are other folks, mainly within clinical organizations, who are saying, we only want CHWs to be reimbursable when they are in the clinic, because they are concerned about being able to effectively supervise people who are mainly operating out in the community. Okay, so the issue of the setting where Medicaid will pay for CHW services is a significant one, and it will be part of your discussions with the state. I mentioned this as part of the billing, but who may refer for CHW services? Who may order those services? The Medicaid regulations say that preventive services must be recommended by a licensed clinician. Okay, who may do that recommending? And who must supervise what CHWs do? These are all considerations in defining this payment structure. Again, part of the good news is in experienced states like Minnesota, they have worked it out with the state that the provider organization can have a standing order for CHW services, so that you don't have to get a hold of a physician and say, would you sign this order so that we can assign a CHW to work with this patient. They can have a standing order, and they are doing that in Minnesota. That's an important concept to remember. And then lastly, and this is a biggie, a lot of people who are interested in CHWs these days assume that they mainly work in healthcare. That is not so. Most CHWs work in community-based organizations. Many of those community-based organizations have never billed Medicaid before. And so the conversations are happening in a bunch of states. The ones I know best are California and Rhode Island. But there are discussions going on, very sincere, about how do we deal CBOs into this? Because there are good arguments to be made that CBOs are the best employers for CHWs. So how can we work it out that they can get paid through Medicaid? Are there partnerships, contracting arrangements that can be done? And this can be done very creatively, I think. So that's a topic that will come up. So this is a summary of the kind of the 6 buckets of issues that I see going on in the states right now as they talk about developing a system to pay for CHWs under Medicaid. And I'm sure we will come back to discussions on this, discussing it further. Before we go on to general discussion, here are some websites. Again, you will get these slides, so you don't need to write all the stuff down. But there are some very good sources. Obviously, you want to study up, do your homework on South Carolina Medicaid itself. But these are useful reference resources for a discussion of Medicaid generally. And I recommend them highly, particularly the Kaiser Family Foundation. It just has some terrific stuff. There are others, if you have specific questions, that I would be glad to help to point you to some other resources. Before we do that, I do want to mention that CHWA itself has what we call our CHW Document Resource Center. And you can find it if you go to the CHWA website. Many of you, I'm sure, I wish I could say all of you are members of CHWA, but even if you're not a member, the CHWA website, nachwa.org, NACHW.org, under the policy tab on the homepage, has a link to the Document Resource Center. We have over 1,000 documents that mainly state level groups have produced about the process that they followed in developing policies around CHWs and the results, what they came up with. So there are documents both about the process and about the results that states came up with in terms of policies around CHWs, which includes documents about financing. We also have on that resource center, we have a specific policy paper around sustainable financing for CHWs. And we're in the process of revising that. It's almost, I can't believe it, it's almost 2 years old now. But that is a very important source document. I know that your leadership folks in South Carolina are familiar with that report and with the Document Resource Center. But I strongly encourage you to make use of that to inform your work going on and going forward. And we'll be glad to help you do that. So I want to pause here. We're going to take another poll before we finish. So I hope you all will stick around for that. But would like to move to sort of a general question and answer. And I have not been looking at the chat because I'm trying to keep up with making a presentation here. But perhaps, Don, if you could help me in spotting some questions in the chat. But I think we're still a modest sized group. If you want to, might be helpful to ask you to raise your hand before asking a question. But if you'd like to ask a question verbally or make a comment, we would welcome that at this time. And I think there's a button for raising your hand, which you can use, or you can do it the old-fashioned way. So I'm going to put my camera back on. And oh yeah, before we do that, our this workshop was sponsored by CHWA. It is hosted by South Carolina CHW Association, sponsored by CHWA and the Center for Community Health Alignment. But I do want to specifically give a shout out to the Rhode Island Department of Health and CHW Association of Rhode Island, who funded the original development of this webinar. So I'm going to go back to the polling in a second, but why don't we go ahead and open it up for questions and comments, either in the chat or raising your hand and taking yourself off mute.
I am looking for any hands raised, but in lieu of that, I did see a question.
Okay,
And
let's
that
start with
came
that.
from Hazel. She asked if there was a comprehensive list of, oh, I see, Chief Mitchum, hold on. Comprehensive list of place that community members can go to get help completing Medicaid applications.
So that's probably best answered by somebody there in South Carolina. I certainly, that is a state by state thing. And you all, I'm sure somebody else on the call probably is familiar with resources in South Carolina that can help people who need to complete an application.
Okay, we will, if you have any, if you don't want to open up and answer that, if you have something, you can put it in the chat regarding that. And we'll
Yeah,
go to
please
Chief,
do. Yep.
we'll go to Chief Mitchum's question.
My question, Carl, was
Yeah.
centered around COVID. In my area, community health workers have stood in a gap in COVID. They don't want to come out. They don't want to, the big COVID scare. The more you are around people, the more exposed you are, blah, blah, blah. But yet we're out. And we're in front of the front line, so to speak.
Yeah.
We're keeping these people in touch with their physicians, things like that. Is there anything that's come down the pike through these CARES Act or anything that COVID related that would would open the door, so to speak, to funding community health workers long-term beyond, because for example, with telehealth, all of a sudden telehealth
Yeah.
went boom, it's everywhere. And
Yeah.
somehow mental health, they get to keep their telehealth. But once the
Yeah.
pandemic is over, doctors have to go back to, I don't know what they go back to. I guess it's Stone Age now, but
Yeah. 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 Great. Thank you, Chief. A big, first of all, thank you for the question. The COVID has, ironically, as tragic as it has really focused attention on what CHWs can do. And telehealth is part of that. In Texas, we have a certification program with general certification for CHWs, as you all are implementing in South Carolina, but we have a separate certification for CHWs to become facilitators of telehealth encounters.
Mhm.
And so it's not just setting up the contact between the provider and the patient, but they get trained on the use of the telemetry equipment that allow certain, vital signs, other clinical information to be transmitted directly to the provider. And this can become an issue when, particularly in rural areas along the border between states where the patient and provider may be in different states even, but I will say again, back to the NACHWA website, there is a whole section of the website now on COVID resources, and that there have been programs in recovery, the CARES Act, and a number of others that specifically single out CHWs for their role and potential investment in building their role in COVID response. Because you're absolutely right, they are on the front lines. You all are on the front lines, and the bad news, good news again. But the good news part of it is that CHWs are primed, highly effective in reaching the populations that are most affected by COVID, both clinically and socioeconomically. The
And
people, yeah,
I guess
go
a
ahead.
follow-up question, because I know we're still full swing in COVID, but do you think that the past 2 years, all of our organizations, agencies, et cetera, that have been at that front line, do you think we have enough under our belt because of COVID that we can go back to the state or our representatives or whatever, that we can go back to them and say, hey, look, I mean, I know you got family health centers and that's great, but they're coming in a mobile.
Yeah.
We're here all the time.
Yeah.
Are we into this pandemic enough? We've got enough under our belt that we can use that as a fallback?
Yeah, you should be able to, I think. And again, you can use the materials on the NACHWA website under the COVID tab on the homepage as a reference for that. There are descriptions of the various recovery and COVID response federal acts that are providing for that. There is also a new bill that has just been introduced with bipartisan sponsorship, has 4 co-sponsors, 2 Democrats, 2 Republicans, which is going to direct investment into the recruitment and training of large numbers of additional CHWs. A lot of what's needed is kind of the infrastructure to employ CHWs and get them the training that they need. So there is more on that. I am not as much of an expert as others at NACHWA on the the federal response to COVID and the investments that are available from that. But yes, I think you should be using that and the fact that the federal government, particularly in agencies like the Office of Minority Health, and yes, in the Indian Health Service, are placing greater emphasis on what CHWs can do. Thank you for the question.
Thank you.
You're on mute, Donna.
Thank you, Chief Mitchum. I'm sorry for those questions. One of the questions I had when you were going through the services that are identified for Medicaid, one of them that I noted was home and community-based programs. I thought I saw that listed. Wouldn't that open up a window for community health workers?
Possibly it is, I believe, optional, and the trick is that most of the services that are paid under that are direct services. So things like home health care, which is entirely separate from CHWs. However, there are some very successful programs as in Arkansas, for example, and this is in rural areas, this is rural East Arkansas and the Delta region, of programs, or this where it's originated, programs where CHWs are connecting people who are receiving care at home, connecting them to community resources that can enable them to remain at home. And I think you can make a very strong case that that kind of support services and resource connection and caregiver support can be a very important adjunct to home and community-based services. So yes, the short answer is yes, I would encourage you to look at the opportunities connected with that. It's going to require a little bit broader interpretation of what home and community-based services means.
Thank you. And also thank you to all the many responses to the question regarding Medicaid and getting support. Yes, SC Thrive is definitely a good resource. We have a question from Sarah.
Hello, thank you for this presentation. It was excellent, 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 so helpful. My experience with changing state Medicaid policy here in South Carolina is limited, but what there is, I often get asked the question, are any other Southern states doing it? And you've referenced a lot of Rhode Island and California and Minnesota, and I've literally heard people say, yeah, what works in California don't work here in South Carolina. What works in Minnesota, we are a totally different beast. And I know Texas has made some progress, but any other states that South Carolina touches that we can point to?
Yeah, well, the first one, yes, you touch, but some people don't consider North Carolina to be a southern state. So, but they have actually made considerable progress, and the state is making investments there. They also have they have adopted a concept.
Y'all can use these in church.
They have adopted a concept of the community health teams that was originated in Vermont, and they have also implemented in Rhode Island. But that's a very valuable one. But they have made several significant investments in CHW services, and I know they are interested in Medicaid in North Carolina. Florida, I would say, Florida has had an active CHW coalition for quite a few years, and they are putting together a new initiative to begin to address Medicaid. They have a lot of the same political constraints that you all deal with, and I think there's some early movements in Georgia, which is your other immediate neighbor, and that's showing some opportunity. The Florida folks, their coalition is actually forming an advisory group involving the state Medicaid office to look at what their options are. But they have, unfortunately, kind of a sad history. Not long after the Affordable Care Act, there was a bill that was making some progress through the legislature, but it used the language about navigation. And because navigators were associated in the governor's mind with the Affordable Care Act, he effectively killed the bill before it got anywhere, even though it was a totally different use of the term navigation. That's why the folks who got, God bless them, the folks who got the Affordable Care Act passed made a tremendous contribution, but I wish they'd used a term other than navigator for the organizations that are supposed to help people get coverage through the marketplaces. There is more confusion about that. In the ACA, the language about navigator means organizations who help people obtain coverage, not individual patient navigators or whatever. So, but those are a couple of examples. Texas hasn't made as much progress as we would like. Honestly, our certification program for CHW has been around for 20 years. And the original legislative intent very clearly was to set it up for CHWs to be paid under Medicaid, and we still ain't there. We have, Texas is also a managed care state. And as I said, there are a bunch of the health plans in Texas Medicaid that are doing their own thing, but not with any policy support from the state. Louisiana is working on a state plan amendment also.
That was a very good question, Sarah.
Yeah, thank you.
And North Carolina with that that ketchup-based sauce, no, they're not southern. No.
Who
Now,
is leading this?
wait a minute. Texas hasn't been heard from here. All right, go ahead.
Too much
But
hot
who's
sauce.
Who's leading the efforts in North Carolina? Is that the North Carolina CHW Association?
They are involved. They're a very fledgling organization. I think they are, my impression is they are behind where you are in terms of organization for their statewide association. That is true. Florida is in a better position, I think, to get back in the game because they've had a coalition now for close to 10 years.
So who's leading this charge with the community health teams in North Carolina? Is it somebody else besides the CHW Association?
I think it is partly the state. I think it is partly their primary care association, frankly.
It's
Which
their
is,
Office of Rural Health.
Right,
thank you.
yeah.
That was Julie chiming in, I assume. Yes.
It
Yeah,
So
thank
you
feels
mentioned-
very top down instead of. trying to
Yeah,
replicate
yes,
community
I
health
think
workers.
that is true. The state has tried to be helpful, but somehow they can't help doing things in a top-down way.
So you did mention the federal legislation that is on the table right now, supported
Yes.
by both the
Yeah,
Democrats and Republicans.
while we're talking about it, it was introduced originally by Senator Casey from Pennsylvania. And while we're talking here, I will look up the bill number. It is,
Because we did talk to Senator Casey's office
yeah, it's
in the
Senate
early
Bill,
days.
yeah, Senate Bill 3479. It was just introduced a couple of weeks ago.
So I talked to Julie about that afterwards, after we realized it was actually introduced, and I wasn't sure, Julie, where we landed because I was waiting to get that information before we promoted it and wanted to make sure everyone calls
Mhm.
our wonderful senators, Tim Scott and our other senator. But if the Natural is fully supporting it, then
Well, I can't really say officially about that right now. I will say, no, your senators have not signed on, but Senator Tillis from North Carolina is one of the co-sponsors.
So
But the concern, the biggest, I would say the biggest concern we have, without getting into more detail, is this is just creating another grant program. And that is, it's great to have the attention and all of that, but grant programs come and go. And the communities served by CHWs are tired of grant programs that come and go. Easy as that.
I just put Nachoa's response in the chat. Nachoa has not endorsed it, but Nachoa did provide recommendations.
Thank you. Yeah, that's the official response that has gone to the committee, actually, the committee that is receiving the bill, or subcommittee, I guess, at this point. Yeah. Other questions, comments? I would appreciate, while we're sort of pausing here, people want to comment either verbally or in the chat about specific aspects of this process and the phenomenon of Medicaid payment, specific aspects of it that you would like to learn more about, so that we can take that up with the CHW Association and with CCHA in terms of their activities.
Also, I'm trying to catch up here. I was reading this that Julie posted, the building a sustainable workforce for healthy communities. Is that in, where is that at? Where is that, federal level, state level,
Federal.
Yes,
federal? And does anybody know which senators or congressmen?
yeah, the sponsors, the initial sponsors of the bill are Senator Casey of Pennsylvania, Tillis of North Carolina, Tina Smith from Minnesota, and Lisa Murkowski from Alaska.
Really? Yes.
Yeah, well, I think Senator Casey's office wanted to make sure from the get-go that they would start out with, at least start out with bipartisan support.
Yeah, I tried to put the draft of the bill in the chat, but it did not work. So it's 205 pages.
Oh, my goodness. No, I don't think that's going to make it into the chat.
No. But
Yeah,
there's
I
a draft
just-
online that Denise sent us, and I'll try to find another way to. I clicked on the link and tried to put it in the chat, but it didn't let me. So I'll try to find another way.
Okay.
well, we can send it to the participants.
Yeah, I was gonna say, if you
Send it
can
in an
send it to
email.
me. And maybe point out specifically what you would want, like honed in on within it. I'll get our tribe to send a letter to our
Great.
senator.
Great.
And it looks like it's got 2 Democrats and 2 Republicans that are co-signers.
Yes.
This is good.
Yeah. Yeah. It's certainly a good start. But again, there are things in the comments, in the response that Julie mentioned, the official response from NACHW. Certainly encourage you to look at those comments as well as the bill itself. And this has been a long time coming, by the way. It's been brewing in Casey's office for, I think, well over a year. Other comments, questions, including priorities for further learning on these topics?
One of the things that Chief Michelle asked in the chat is, you know, what can we do as CHWs and who do we contact in our state to move something forward? And, you know, I think once we land on what our ask is, it would be great to have some talking points, because to make them listen to us, they want to hear from their constituents, right? So like where I live, I need to contact the people at the State House that represent me, and vice versa. But we'll need to have some like talking points about what our ask is for all of us to like contact our, I don't know that we totally know that yet.
Yeah. It is a little bit of a chicken and egg thing. I mean, totally agree that support of individual legislators, particularly legislative leaders, is really crucial, but they're going to want to know, you know, what is it you're asking me to support? You know,
Should we
which is
create,
understandable. Yeah.
should we, like Donna and Julie, you know, should we create like a committee just for that within the association? Or
Well,
is there one already?
Well, there's not a committee, but there's definitely, like Julie was saying, we definitely want to craft the communication. And that's why I was asking about where NACHWA landed, because I think we want to line up with them so that our ask is one large voice and everyone's speaking from the same sheet of music.
Mhm.
And if that comes from the NACHWA, if we can look at what the NACHWA has said in their comments, and we can align with that, if we all
Mhm.
agree, then that would be, I think, where we start.
Well, I think there are a couple of things going on here. One is a response to some federal legislation, but that really has nothing to do with Medicaid.
Right.
And so it's like you're probably going to be operating to some extent on multiple fronts. Medicaid is where the money is, and so if there is a strategy that you can convince not just the state but other interested parties, okay, provider groups, community-based organizations, the health plans, convince them that this will help them meet their objectives. That's going to be really important. So it's a matter of really communicating a unified message about what you would like Medicaid to do. And it will require showing these other parties how it would benefit them as well to do what you want to do.
Are there any other questions?
Oh, I would add very briefly, I'm sorry, Donna, that the one of the big issues is what can Medicaid, the state Medicaid office, what can they do unilaterally without legislative cover, so to speak. Some states, the executive branch, the Medicaid office, can develop and submit a state plan amendment, an amendment to the state Medicaid plan on its own. In other states, they require legislative authorization to do that. And I don't know for sure what the situation is in South Carolina, but some states, they don't need the legislature to approve it. Now, it also has happened in several states, including Rhode Island and California, where the governor has taken the initiative to propose a budget amendment to cover Medicaid reimbursement for a CHW benefit in Medicaid. And that has succeeded in both states. There's some federal legislation in several states, including California, have appropriated funds sort of for the infrastructure that's required, like for the recruitment and training of CHWs. You need an ongoing sustainable source of payment for their services, but you also need the initial investment to get people hired and trained. And so there's HRSA grant money out there now for that. I don't know how much of it has already been awarded, but there's HRSA money for that. And California adopted a budget amendment to make funds available for that kind of activity too.
Wonderful. We have about 4 more minutes. I know you wanted to do the ending poll to see where people landed.
Yes, I do want to do that, but I want to make sure everybody gets a chance to say the piece or ask their question.
I am checking the chat for additional questions. I see that Linda had a question and Terry responded regarding capitation.
Yeah, yeah, yeah. I
Did
just
you
made
get,
this, I'm sorry.
did you get the answer you needed?
Well, I was really just stating that I would like more information, or well, additional information or additional training on capitation of CHW services, if they're classified as administrative, and what that really looks like, because I'm pretty sure there's a process by which capitation could possibly exist within our Medicaid system in South Carolina, but I'm a visual person, so I kind of need to know how that's going to look, even if it's not just how it would look on paper. What does that look like? Because a lot of it is not theory. Well, yeah, it is. It's been proposed.
It's
It's
both. Yeah.
theory. So therefore, what does theory look like in reality?
Mm-hmm.
What does that look like?
Sure. Well, if it were proposed as Medicaid health plans, the managed care organizations paying for CHW services out of their capitated payments, they would have to either propose it themselves because they see that it would benefit them in the long run as a result of savings of total cost of care
Yes.
for their members, or else they would need to negotiate an adjustment to their capitation rate. They have in New Mexico, the health plans have a mandate to provide CHW services and care coordination. And I believe they negotiated an adjustment to their capitation rate in exchange for meeting that requirement. They have a similar requirement in Michigan. The health plans must provide a certain amount of, and I think that's out of their administrative expenditures.
Okay, okay.
Yeah,
Okay.
yeah.
Okay.
And what they, yeah, if it's capitation, it has to be, the expenditure has to be either part of the cost of care or what they call their total claims cost, or else it needs to be treated as administrative.
I understand it now. I got you. Okay, I get it now.
Okay,
Okay.
good, good.
All
I
right.
get it. I get it. I get it.
Thank you, Linda. And thank you so much, Dr. Rush. You see, I've just given you a title.
Oh, yeah, promotion. Wow. Yeah.
Yes,
Well, we do want to get that,
the poll
uh,
going.
yes.
So I'm going to
So
put that
let me
up.
go. If you could, this essentially the same question. Shouldn't only take you a few seconds to answer. If you could go ahead and put that question up, please, Donna.
Okay. If you all can go ahead and respond, hopefully you see that. Very good. And while they're responding, I must say there's been a lot of people in the chat that feel the way I do. This was amazing. So much information. I'm so glad we recorded it. And these slides are available because we will definitely go back to look at them.
Okay, I think we can probably close out the poll and see what the responses look like. Wow.
Wow, we
Hey.
got rid of all the not at all confidence. Awesome.
Hey, this is a hot group. Look at that.
South Carolina's smart.
No, yeah, well, it's a smart group, but I mean, nobody left who's not at all confident. That's that's pretty great. That's pretty great.
Awesome. Well,
All right.
so appreciate you for taking the time.
Well, thank you for the opportunity. I always learn stuff from this. I want you all to know that this is a two-way street for me. I appreciate being able to share what I've been picking up, like a honeybee going from plant to plant here, sharing the pollen. But it's great to be able to learn from you all as well, and the issues that you're dealing with and what your goals are. So thank you for the opportunity, and look forward to continued work with you all in some capacity. So, let's all get out there and be fruitful and multiply.
Yes, we will. We'll share it, and one day we will get this. We will get this together.
Great.
Be able to support our communities. Thank you again, and thank you everyone for coming and hanging out with us and being your true, authentic selves and providing so much good questions. Y'all have a great rest of your afternoon.
All right.
Right.
Take care.
Some people may just be.
Oh, I just saved Donna. I just saved the chat, so you don't need to send it to me.
Oh, okay. Good, good, good.
All right.
And Chief Mitchum, again, it's so good to see you. It's been a while. So hopefully I'll see you again soon. She may be vocally off.
Yeah,
All right. And Marek and Joe, I think they're probably just hanging on. See you later. Thank you.
Thank you.